Hi, I'm Alex Garbarino. I'm one of the second-year pulmonary critical care fellows here at UC. And as you guys are going to be helping us out in the ICU, I thought it might be helpful to go over a quick discussion about shock, differentiate the various shock types, talk about the things that you should look for in both a clinical and a laboratory sense when you're evaluating a patient in shock, and then get into a quick discussion of some of the pressors that we use in the ICU. So, real quick, a definition of shock. Basically, at its most basic stance, a patient in shock is a patient who is not perfusing their end organs. What's an end organ? Pretty much anything that the blood is designed to deliver oxygen to. Okay, that's everything from the heart, the lungs, the brain, the liver, the kidney, the skin. All of those things are considered to be end organs. And if you've got a patient who's not delivering appropriate oxygen to those tissues, that patient is in shock. Okay. When I went through medical school, and potentially even when you went through medical school, I was taught to look for the patient in shock based on certain clinical criteria. Those clinical criteria are usually based around a specific subtype of shock called septic shock because of its prevalence in our population. But in general, you should be thinking of anyone that could be in shock if they're developing any kind of end organ dysfunction. An important thing to note is that a patient does not have to be hypotensive to be in shock, and just because a patient is hypotensive does not necessarily mean that they're in shock. All right? So, now that we've kind of defined that out, what do I think about when I'm going to evaluate a patient for shock? Certainly, even though I just said that they didn't necessarily have to be hypotensive, I'm looking at those vital signs as part of my clinical exam. So the first thing I do, of course, before I do anything else is a clinical exam, but you're looking at vitals, specifically blood pressure. Talk about why in a second. I'm looking at heart rate, I'm looking at temperature, I'm looking at respiratory rate, the whole 9 yards. All of these things not only telling me whether they're in shock, but helping me differentiate eventually what type of shock they're going to be in, okay? And then outside of that, on my clinical exam, I'm looking for those signs of end organ dysfunction. So if it's an organ that consumes oxygen, I should be able to see clinically if there's something wrong with it. Most common, altered mental status. The brain is a voracious consumer of oxygen, and if it's not getting perfused well enough, the patient's going to be altered. So mental status is huge. Capillary refill, okay, usually assessed by pinching the skin just above the nail bed here. If you believe some of the literature on it, you should hold for about 10 seconds and then let go and see how long a time it takes for the capillary bed there to be reperfused. Capillary refill has been shown, when done appropriately with a timer, not just somebody counting in their head, by somebody who's trained how to do it, capillary refill has actually been shown to be a better endpoint of resuscitation, at least on par with trending serum lactates, which is something I'm sure you were all trained to do at some point. So, capillary refill, very important. Other things to do with the skin without mashing on it, okay, modeling, and even just temperature. Put your hand on their feet, put your hand on their fingers, these distal parts of the skin. Are their extremities cool? Are their extremities warm? Not only will that help you determine if they're in shock, but again, it'll help you differentiate the type later on, okay? And then usually during the course of my clinical exam, because I'm an intensivist, I just look at them and see if they look sick or not. That is a clinical gestalt thing that you will pick up with time, but often you can look at a patient and know relatively quickly whether they need to come to the ICU or not. And vital sign I forgot to mention up here is going to be oxygen saturation. That'll tell you again if there's something wrong with the lungs or possibly the heart. You're just looking for signs of end organ dysfunction. All right, so let's talk about laboratory evaluation. Again, some of the organs we don't have a great way to clinically examine to see if they're dysfunctioning, but they show up great on labs. Top two that I can think of are the kidneys and the liver, right? So I want a renal profile to see, is there creatinine worsening? I want LFTs, and because it's an acute situation, I expect to see an elevation in transaminases. Later on, with time, as the liver's had a chance to die off a little bit more, bilirubin may start to go up, but in the acute setting, I'm mostly looking for these transaminases, okay? A CBC is never unhelpful. You're going to be able to differentiate the type of shock that's going on a little bit better. The white blood cell count and the hemoglobin may help you with that. Occasionally the platelet count as well. Platelets can be up and down for a lot of different reasons, but certainly for shock differentiation, the CBC is very, very helpful. Serum lactate is a global marker of perfusion. A lot of things release lactate into the bloodstream when they're not being perfused. So if the patient's lactate is elevated, that's great for diagnosis. It doesn't help so much to tell me what organ is being dysfunctioned, but any lactate greater than 2, I would consider to be abnormal outside of another clinical scenario, such as a cancer, for example, that would raise their baseline serum lactate. Incidentally, most of these tests, with maybe the exception of the CBC, are tests that I'm going to follow on a serial level to see if the patient is being resuscitated appropriately once I start trying to treat their shock. A lot of times the serum lactate is going to come along with an ABG or a VBG. I will save my soapbox speech differentiating ABGs and VBGs for another time. Mostly at this point, I want to know whether or not the patient's pH is being drastically affected by the lactate. So if the patient is grossly acidemic, for example. If during my clinical exam I had noticed that the patient was hypoxic, I would of course gravitate to that arterial gas so I could get an idea of how bad their arterial oxygenation actually was. So now that we've talked about things to evaluate in a patient that's in shock, some of those from diagnostic purposes and some of those to help stratify the type of shock that they're in, let's go into a deeper discussion about the 4 different types of shock and the hemodynamic parameters that are affected